session, and we'll be moving forward with the next session, which is about COVID aftermath and painful reverberations. For the chairpersons, may I invite Dr. Nichlani BK, Dr. Abjeet Kaur, and Dr. Jagdish Rana. Moderating this session, we have Dr. Jagdish Rana. Over to you, sir.
Yeah. Good afternoon, everyone. Now we are going to start our session on COVID aftermath, painful reverberations. I believe all have joined. Dr. VK Nichlani, Dr. Abjeet, and Dr. Jagdish Rana are.
Yes, I'm here.
Yeah. Panelists are.
Dr. Bhalla, there is a little issue with my video. So
Okay,
I can hear everybody, but my face is not visible.
Okay. Can audiovisual person please help Dr. Abjeet Kaur, ma'am? So that we can.
Ma'am, please.
I can see the presentation,
Okay.
and I can hear you and see you, but my video from here is not going. Yeah.
Your video is not showing here also.
Yeah.
So you can,
this link and
ma'am, you are join again. Just.
Hello, Dr. Bhalla.
Yeah.
I've been trying
Hi,
it
Dr.
since
Anuj.
morning. This issue is happening since morning. It happened in the morning session also. So
Please
we can start off. No
Okay,
issues.
we can.
Okay.
Meanwhile, audiovisual person can help, ma'am. And we have as panelists Dr. PV Chadda, Dr. Vinita Ramnani, Dr. Amit Shah, and Dr. Manpreet Bhalla. So I'll invite the first speaker is there, Dr. Anil Bansal. Has he logged in? Dr. Anil?
No, Dr. Jatendra, Dr. Anil is not here.
Okay, so we can meanwhile ask the second speaker, Dr. Anuj Mittal. Dr. Anuj Mittal is head of the department psychology, psychiatry at Deen Dayal Upadhyay Hospital, and he's going to talk on psychological impact of COVID and lockdown. And discussant for the talk is Dr. Jagdish Rana. Over to you, Dr. Anuj, all yours.
Thank you. Can everybody see me on my screen?
Yeah, we can see you, Anuj. You can share screen.
Yeah, can you see my screen now?
We can't see your slides.
You can't see my
So
slide?
share your screen, sir.
I have shared the screen. Yes. Can you see my slides?
Yes, sir.
Yeah, we can see, sir. Please.
Yeah, good afternoon, everybody. Last 1.5 years, we are all going through the COVID and its related problems. WHO declared COVID as a pandemic in the March 2020. And most of the health authorities were really focusing on the increase, the amount of the diagnosis, and the management and the contact tracing, and on the later phases, regarding the prevention, and which is of course by the vaccination. But there was a very little focus on the mental health or the psychological health of the people who were going through this all pandemic. Now, if you see psychologically, there are various group of people, the different group of people who have been affected differently by their circumstances. There was general population, there were healthcare professionals, there were people who were isolated in the quarantine, people who were COVID positive and recovered, and people who already had psychiatric or psychological problems, and long-term impact on all the groups. Now, psychological and behavioral responses of the general population in the lockdown there was increased anxiety and fear in everybody. And they were really worried about the health of the self and the loved one. And everybody was concerned that I may contract the illness, or my close family member may have contracted the illness. There are symptoms of low and irritable mood, anger and frustration, restlessness and agitation. And as predicted, there was increased conflict with the family members because most of the family members were working from home, or they were at home. Most of the children were at home. Therefore, there was increased conflict for their space at the home, their agreement and disagreement. Increased use and withdrawal of the alcohol and tobacco. Since alcohol was not available to people who were actually dependent on the alcohol, they had few withdrawal symptoms initially. And when it became available after the opening of the first lockdown, people started storing the alcohol and the tobacco related products. So in this second lockdown, there was a sharp increase in the use of the alcohol and tobacco. Sleep related issues, as predicted, people were going to sleep late and getting up late. There was difficulty in the sleep, concentration problems, and impaired daily performance because they were at home, working from home. So there was no hurry to get up, no hurry to go to office. There were racing thoughts, especially the negative thoughts related to the COVID, whether what will happen to that COVID. Feeling of helplessness of being not able to do what everybody was doing every year, going out with the family members, going to their places frequently, going for traveling. Those all things has stopped. Suicidal tendencies developed, and few may develop syndromal disorders such as depression and anxiety and trauma related disorder that require the formal treatment. One thing I'll add here is the a word is known as infodemic, means there was excessive exposure regarding the information regarding the COVID. That also led to a lot of anxiety and apprehension because all news are not relevant and not authentic, all sources. So many things has happened in last 1.5 years. Now, let's look at the population who were isolated in the quarantine. They showed symptoms of anxiety, low mood, irritability, emotional exhaustion, being in the same room for a very long time, unable to do any physical activity, no exposure to the light, and inability to sleep. There were difficulty in the sleep, trauma and stress related symptom, because there were uncertainties that how their day-to-day needs will be met, and their day-to-day medication, their looking after, who will give them food. So this was happening in so many houses. Few people committed suicide because of the loss of job, the loss of financial things, their depression, and related complications of the COVID. These symptoms could outlast the period of quarantine in the vulnerable population. Last 1.5 years, we have seen so many people, let's say 99% people who had COVID recovered from the COVID. But after the recovery, many of them reported the cognitive and memory related problems. Many doctors who recovered from COVID, they came to me and said, yeah, there are difficulty in focusing, in concentration, in taking the clinical decisions. So that was a very important factor. But ultimately, it improved itself after 4 to 6 weeks. Sleep disturbances, anxiety and panic symptoms, of course, because when you recover, you just think about what will happen if I contact it again, and what will happen if this happened to my family members. Prolonged fatigue. After infection, even 3-4 months of fatigue, people are reporting. Body pains, helplessness and hopelessness, because they were not seeing any end of the pandemic. Although vaccine had some positive influence, some hope, but still. Long-term psychological impacts of the COVID were seen in the terms of post-traumatic stress disorder, in which there are the anxiety symptoms and recurrence thought regarding the COVID, and there is always a fear that I may be infected. Anxiety problems, which includes the panic and palpitation and sweating, drug abuse and dependence. In the United States, it has been found that last 1 year, the sale of the cannabis increased multifold. See, because of the lockdown, people were inside the home. The increased use of the various kind of drug were there. Depression, adjustment problem to the new environment. Everybody has to work from home, and few people lost their businesses, their jobs. So adjustment problems were likely to happen. Special emphasis on all of us healthcare professionals. Increased patient demand during 1.5 years, risk of acquiring infection to the self and the family members. Equipment related challenges. So many people were working in the corona wards, wearing PPE, wearing masks, wearing various kind of protective gadgets. And also imagine about a person who's in the ICU and looking after the patient on the 3 types of the ventilators, and emotionally challenging experiences like death around and suffering around, in which they can't help so much that they want to. This is a psychological first aid tool which was developed by the Canadian Psychiatry Association and recommended by WHO now for specifically COVID-related anxiety. This is for the general population. ABC123. This is available online. Anybody who has an anxiety, stress which is related to COVID should just log in and just type ABC123 psychological first aid tool. You will get all the information. This is very easy to see. It's a self-administered tool. When to consult a psychiatrist or a psychologist or a mental health expert during the corona periods, when there is excessive sleep related issues like delayed sleep cycle, insomnia or hypersomnia, uncontrolled anxiety, palpitation, restlessness, agitation, panic, excessive sweating, moderate to severe depression like helplessness, hopelessness, suicidal behavior, suicidal ideation, alcohol or illicit drug related abuse.
Yeah, I'm there now.
Excessive use of alcohol and drug related issues like tobacco, cocaine, cannabis, opioids, then that individual should need help. Post-traumatic stress disorder, as I discussed, unresolved grief, which is a very important issue because many people lost their loved one. Just a minute only. Unable to cope with the death of the family members. Just I'll take half a minute. Unable to cope with the death of the family members and the friend. There was a survivor guilt, which we know that I have been survived, my close family member has died, and I'm unable to help my close family members as I should. Worsening of the existing psychiatric symptoms. Therefore, these are the main guidelines when we should expert a mental health professional. Now, we all know that this corona pandemic will remain with us. Waves will come and go. Let's see how much vaccination we can do. This is in the last 1.5 years, we have seen this is one of the worst pandemic of human history in 100 years. It has a very
Anuj, can you summarize, please?
Psychology or well-being of the large segment of the population. We need to increase the awareness and availability of the psychological support for everyone. Thank you. Thank you, Dr. Bhalla.
Yeah, thank you. That was a very wonderful presentation, Dr. Anuj. I would invite the discussant, Dr. Jagdish Rana, for talk of Dr. Anuj. So, a few questions for you, Dr. Jagdish.
Yeah.
Yeah. So, how do you think this COVID pandemic and lockdown has affected ophthalmic patients psychologically?
You are asking me to Dr. Anuj Mittal?
Yeah, Dr. Jagdish Rana, please. Dr. Jagdish.
Yeah. And also, Dr. Bhalla, thank you very much for inviting me in this COVID aftermath discussion. So this COVID has affected massively to the ophthalmic patient in a especially second wave, and especially the fear of the mucormycosis is very much there. I have got at least more than 50% patient in my OPD practice during these mucor cases, especially in the Gujarat, where the mucormycosis cases has been tremendous. And even we thought without the COVID, patient who has got the COVID, they are also coming to that where they are able to get COVID or mucor, or even patient without COVID or with COVID, both are coming. And especially they are afraid of either getting mucormycosis or either they are chances of getting removal or enucleation of the eyeball. They are very much afraid of enucleation of the eyeball. That's why they are coming very much frequently. So in my opinion, in my practice, 50% of patients, because of fear of mucor and enucleation of eyeball, they are very much affected. Yeah.
How do you handle their stress levels, sir, of these patients?
Yeah. First is the friendly approach is very much needed. We have to approach them friendly as if we are a family friend of their patient. Second thing is a scientific approach. We have to examine, we have to rule out all possibilities of other COVID-related issues. And if everything is normal, then we have to explain that we are not having a mucor or any other infection, or not even chances of getting the infection. Second thing is we have to investigate. In some cases, if we find out some doubt of a arterial occlusion or venous occlusion or a doubt of a mucor, then we have to ask for the HRCT or a CT scan PNS as well as D-dimer level. If these are also normal, then you have to explain that you are not having any chances of getting loss of the vision or enucleation of eyeball. And regular follow-up at a short interval is also very much important to handle this patient space.
I think very rightly said. I'll thank both Dr. Jagdish Rana and Dr. Anuj for excellent talk and discussion. Now invite Dr. Anil Bansal. Has he joined? Ekta, has Dr. Anil Bansal logged in?
No, sir, not yet.
Okay, then I'll invite the next speaker, Professor Deepti Nair.
I've logged in.
Dr. Anil.
Okay, Dr. Anil has logged in. I think we'll
Yes.
continue with talk of Dr. Anil Bansal. Dr. Anil Bansal is interventional cardiologist at Dubai and Sharjah, and previously he was faculty at Wisconsin Hospital, California. Dr. Anil Bansal, you are going to talk on clotting disorders and other hematological issues post-COVID. All yours, Anil.
Yeah, hi. Can you hear me, Chetan?
Yeah, we can see you. You can
Right.
start share screen and open your slides.
Okay, just hold on. How do I?
First, you open your presentation.
Yeah, I've opened the presentation.
Then you press this green button on the bottom, share screen. On the bottom, green with the arrow.
You can.
इसमें वो शेयर वो जो पिक्चर
इसको
इस पे क्लिक करें, इस पे जूम पे क्लिक करें, जूम
इस पे
पिक्चर पे
इस पे
इसमें यार कहाँ गया वो वाले इस पे क्लिक करें ना, इसमें होगा।
Meanwhile, Dr. Deepti, you are there?
हाँ इसमें होगा
Ekta,
ना।
has Deepti joined?
Yes, sir, I'm here.
Okay.
स्क्रीन करें ये करें।
Sorry.
Yeah.
स्टॉप शेयरिंग, शेयर, सिर्फ वो अपने प्रेजेंटेशन चूज करनी है, ये प्रेजेंटेशन।
Yeah. Jitendra?
Yeah, we can see. Start slide share, Anil.
Yeah. Okay. So you can see the slides now?
We can see.
Okay. So good morning, ladies and gentlemen. So I'm going to talk about clotting because anticoagulants is something which we deal with quite a bit, and it has really increased in the COVID era. I'm going to just start off with a case which I picked up from the August issue of Journal of Stroke and Cerebral Vascular Disease. A 48-year-old man with obesity was hospitalized with severe COVID, complicated with acute respiratory failure, septic shock, and dilated cardiomyopathy and fungemia. Despite treatment with enoxaparin, his D-dimer continued to rise above 20 and continued to spike fevers, and this prompted us to do an upper and lower extremity, which confirmed DVT in both areas, and enoxaparin 1 milligram per kg body weight twice a day was started. The D-dimer decreased while on therapeutic anticoagulation, but 3 weeks later, pending hospital discharge, the anticoagulation was switched to oral apixaban in its loading dose 10 milligram twice a day, but the patient developed acute severe right eye visual loss with no light perception and was diagnosed with incomplete ophthalmic artery occlusion. D-dimer was still elevated to 2.13. Stroke radiological workup showed no embolic source. Resolution of dilated cardiomyopathy was noted with a negative antiphospholipid antibody. Treatment was changed from enoxaparin to enoxaparin from apixaban, and no further thrombotic episodes were noted. I present this to highlight the amount of thrombogenicity which is available, and what we don't really have an answer is what is the best way to treat, whether it is enoxaparin or the novel oral anticoagulant agents. And the problem is we have to go back to the physiology of the Virchow triad. 100 years ago, Rudy Virchow said that venous stasis, activation of blood coagulation, and vein damage was the three things which was leading to a coagulative function happening in the body. And this is exactly what is happening in the COVID. I know this is something which we don't like to know about, but we have to be aware. The extrinsic and intrinsic pathways leading to the common pathway and then coagulation. I want you to highlight that the extrinsic pathway is much quicker, much more virulent. And in COVID, this is what is happening. If there is extrinsic pathway through COVID virus, which is causing endotheliitis and direct thromboinflammation and direct clotting. So it is a much more virulent form of extrinsic system, um, which is activating the cascade, leading to the conversion of prothrombin to thrombin, and then thrombin acting on fibrinogen to make fibrin and then subsequent clotting. Now, here is what is happening. The SARS-CoV is causing thromboinflammation and endotheliitis. It's basically causing endothelial inflammation, which is leading to an extrinsic pathway activation of the coagulation cascade. I want you to sort of concentrate on this. The upper slide is where the inflammation and thrombosis is happening. This is in the milder and the earlier form of COVID, and where the protective immune response has not yet kicked in. So this is from 0 to 10 days of COVID infection. As you can see, a large majority of these patients do become better, and they develop memory of the T cells and B cells, and then it resolves, and the inflammation is not that severe. But when severe COVID happens, that is when the protective immune mechanism of the body, which is through the dead virus, takes over. That is the time when you have a hyperinflammatory phase, especially from day 10 to day 25. And that's when you're getting really into problems of coagulation, of DVTs, of massive pulmonary embolism as a major cause of death and morbidity in the ICUs, where we are treating these patients and sometimes on ventilators. Why is this happening? As you know, the SARS-CoV-2 receptors to get into the body, and this causes angiotensin 2 mediated injury in the vessel wall. It also causes complement activation, and this again causes the activation of the coagulation pathway. So again, the extrinsic pathway coming in place and causing hyperinflation, coagulopathy, alveolar injury, and endothelial disruption. This is, I think, a slide for ophthalmologists for you to sort of kind of understand that why is this happening in the venous system. From the Virchow triad, we know stasis is much more prevalent in the venous system than the arterial system. That's why deep venous thrombosis, pulmonary embolus, sagittal vein thrombosis, all kinds of venous thrombosis are coming into play because of the greater amount of thromboinflammation happening because of stasis, because of the greater amount of COVID virus hanging out in the venous circulation, and therefore activating the Virchow triad. And what I also want to the direct inflammation which is happening due to COVID is causing tissue factor activation, which is again causing the external or extrinsic coagulation to get activated, which is directly creating thrombin from prothrombin. And it is thrombin which is causing platelet activation and not the other way around. Normally, in the intrinsic pathway, in the acute coronary syndromes, we have the intrinsic pathway, the platelet activation happening, and then plaque rupture is happening, and then thrombin is forming. Here it is the other way around, because here it is an external injury. It's an external agent causing thromboinflammation and and endotheliitis, causing severe thrombus formation and thrombotic inflammatory changes. Again, this further, the thrombin itself is also activating the complement pathway. It is activating again through the plasmin, again acting through creating further thrombotic and inflammatory changes. The question is, what do we do? Now, inpatient, we are quite clear that inpatient, if they're in the ICU, we start them on prophylactic enoxaparin, about 40 milligrams subcutaneous per day. There are now some, if there is a mild elevation of the D dimer, by the way, D dimer is nothing but a fibrin degradation product. You know, for you to understand that, it is basically a product of fibrin.
Can you summarize, please?
Yes, sure. And so in this, we have the ultimate pathway from the European Society of Cardiology for patients who are admitted with COVID, with symptoms and high risk of thromboembolism, admitted to an intensive care unit. We can either give them unfractionated heparin or enoxaparin 1 milligram per kg body weight twice a day. If they are low risk for thromboembolism and have a D dimer which is normal, or a D-dimer above 3 or greater than between 5 and 3, we do an intermediate and low and a high dose. If it is greater than 3, then it is definitely full dose. Otherwise, it is for the intermediate, it is 40 milligram twice a day. And for low dose, low risk, it is 40 milligram once a day. So 40 milligram once a day, 40 milligram twice a day, and high dose is 1 milligram per kg body weight twice a day. Thank you.
That was very nicely explained, Dr. Anil, and thanks for giving us example of so many cases also from the literature. I would now like to invite Dr. Nichlani, sir, to answer some of the questions of these clotting disorders related to our ophthalmic conditions. Do you think, sir,
hello,
in COVID-19 patients? Hello?
Yes, your question was,
Yeah,
yes, please go ahead.
Yeah, is there increased incidence of retinal venous occlusion cases in COVID-19 patients?
Yes, we have seen, we ophthalmologists have basically seen increased coagulation, venous coagulation related ocular problems, particularly in older patients. We do get more incidence, but yes, we have seen in the younger age group as well in this post-COVID and COVID era.
And younger patients, bilateral cases are being seen. And do you think, as Dr. Anil Bansal mentioned, are the clotting disorders and hypercoagulability are the factors responsible for these RVO cases? And
Yes.
what particular factors do you think are to retinal venous occlusion cases in our patients?
Yes, particularly in younger patients, there are two pathologies, as already explained by Dr. Anil. One is the hypercoagulability. Another is a inflammatory process of the vessels, particularly the vasculitis. So these are the two pathologies which lead into a problem of venous occlusion in younger patients as well. And presence of hypertension and diabetes, which are the comorbidities particularly seen in these patients, has increased the incidence.
And do you think we can start some prophylactic measures in these high-risk group of patients with
Yes,
comorbidities?
I would say that we should monitor the hematological investigations, particularly if D-dimer is gradually increasing in these patients who were admitted to hospital for COVID kind of problems. We must start with antiprophylactic depending upon these hematological investigations. The ecosprin or anticoagulant therapy, that has to be continued for next practically 1 to 3 months after the COVID, and it has to be re-evaluated again and again by your physician to get rid of all these problems and to stabilize to a normal situation.
Okay. I think with that, we come to the end of the second topic, and now I would like to invite Professor Deepti Nair to deliver her talk on opportunistic infection in and after COVID. Dr. Deepti Nair is professor in Department of Microbiology, Safdarjung Hospital and Vardhaman Mahavir Medical College in New Delhi. Dr. Deepti Nair, all yours.
Thank you so much, sir. This is really an honor, and I hope I can abide by time. So I'm trying to share screen.
Yeah, I would request you to please stick to the time.
Yes, absolutely. We shall race through it, and we can always discuss later. So I modified the topic a little. Yeah. It was given to me as opportunistic infections, but I'm going to talk a little bit about immunity also. And
okay.
Yeah. So So yes, this is a cluster of graphs over here, and if you see that India is actually on the top in many places. We have a very large number of cases. We have gone through both the waves. We share a large part of this pie in the cumulative cases, and we are the darkest maroon because we have actually crossed 1 million cases. But the good news is that luckily, unlike its other sisters, SARS-CoV-2 has a mortality which is still under 3% overall. So as a microbiologist, this interests me, but I'm sure as clinicians, you must be wondering, why have I put this slide? This is with a reason, because I want you to look at this group of cousins of the alpha and beta coronavirus. They're all waiting actually to change and become human pathogens. So we have quite a lot of worry in store. Or, the initial pathogens were actually common cold viruses, these ones mentioned over here. What started changing was somewhere in 2003 when SARS-CoV-2 came up from China, and then became a serious infection. And now we have SARS-CoV-2, which has become a pandemic. And in between, there was MERS, which was well contained. Here again, this is a microbiological, dream to actually see the virus structure. But all I want you to understand from this is it's an RNA virus. And as Dr. Manpreet will very well know, being a co-microbiologist and a senior, RNA viruses mutate a lot. Their replication is full of error, and because of that, they create a lot of clades or strains, and because of which what we are seeing right now, multiple strains have emerged. And also it has a huge RNA genome, which allows for more and more mutations. Another thing is it has a very, very, very potent protein on its surface called the spike protein, which actually causes both immunity and possibly immune-related issues also. Overall, the knowledge of immunity is actually sparse, even with the older cold viruses which were caused by corona, and even with the serious ones like SARS-CoV-1, MERS, and COVID-2. What we do know is that immunity is short-lived, and variants will emerge, and also reinfection happens, as we are seeing now with SARS-CoV-2. The first limb of immunity is always innate immunity, what we know as skin and mucosal membrane, things like that. In the case of COVID, what we see as the first defense mechanism are the macrophages, and unfortunately, they get dysregulated, and that results in what is known as the cytokine storm. This cytokine storm is not like the usual cytokine storms which happen and end in, they're acute, they have huge levels of IL-6 and ends in shock and death, which is usually seen in gram-negative sepsis or tumor-related CRS. What we see in COVID is actually shock is hardly there, and death is due to respiratory failure. IL-6 levels are low and it's macrophage dominant. So the innate immunity actually goes for a 6. The protective immunity is possibly because of this one antibody. And please, everybody should remember, because there's a lot of marketing of ELISAs which are testing for all kinds of antibodies. What we have to look for is, are they looking for anti-receptor binding domain neutralizing antibody? Because that is the protective one. And this not only protects directly, it also acts on other cells and induces memory and leads to protection. This is one of the members which is definitely involved in protection. IgA is the first immunity which develops, and when we are talking of neutralizing, we are actually talking of IgG. This is just a tower, and what all I want you to see is that all these are the antigens. And right now, all we know of is the spike glycoprotein, but there are many inside here. We don't know actually, there are antibodies and cell-mediated immunity formed against all, but we don't know if anything is really protective. In cell-mediated immunity, we have both helper and suppressor T cells. They are primarily acting against a spike. If there is a helper T cell response, which is Th1, which means it produces a lot of gamma interferon, then we have protection happening along with the neutralizing antibodies. This is the evidence as it is now. What is definitely seen and what marked, why people went back and looked at cell-mediated immunity was that lymphopenia was continuously seen both in first wave and second wave. In fact, this is very much like HIV actually, where there is something called T-cell exhaustion. HIV directly acts, and we very well know it acts on CD4 cells and kills them. This, we don't know exactly how this, it's possibly by something called overstimulation. Platelets are also, there's been an entire wonderful lecture before me about platelets, so I won't really go into that. Platelets are also playing a big role. But another very important thing is that SARS has a direct effect on immune response genes. So it controls even the genetic manipulations leading to immunity. This leads to a decrease in IFN production, that is interferon. It leads to increase of fibrotic and inflammatory mechanisms. And all your cell-to-cell receptor, activities are controlled and either dysregulated, which is why, again, the abnormal cytokine storm and inflammatory and coagulative process. So the whole thing in the first wave started with something called immunity passport. What we do know is there is no immunity passport. There's probably an immunity signature. In severe disease, IL-6 will be raised, lymphopenia will be there, and neutrophilia will be there. So low lymphocytes, High neutropenia, simple test to do. TLC, DLC, raise CRP, you have a problem in your hand beyond the first week. So a balanced immune response with high anti-RBD neutralizing antibodies and Th1 is possibly protective. So what are the infections in COVID? There are different kinds of infections. When you say co-infections, they are happening with COVID. Superadded or super infections or opportunistic infections happen usually after COVID is over. And then, of course, there is hospital-acquired or healthcare-associated infections. Now, maximum documented are obviously pneumonias and sepsis, and usually multiple pathogens. It's a killer disease. The mortality goes, incidences and prevalence is more than 50%, and mortality is more than 70 to 80%. West has documented more than 50%, but it's actually far more than that. You have virus with fungi or mixtures of.
Deepti, can you summarize, please?
Themselves. So in the eye, the infections have been staph, alpha hemolytic strep, anaerobic, candida, aspergillus, and of course the influenza. There have been predisposing comorbidities, which everybody knows because so much has come out on WhatsApp. But the most important thing has been the misuse of steroids. And I think I would like to leave you with this slide. Everything we do before a pandemic will seem alarmist, and everything we do after will seem inadequate. I think we're seeing this quite a lot. Thank you so much for the patience.
Yeah. Thank you, Dr. Deepti, for that wonderful lecture. Now, I would invite our discussant for this talk to answer some of the questions which are relevant to our ophthalmologist. Dr. Manpreet, are you there? Yeah. A cluster of COVID-19 patients have developed endophthalmitis. Do you think, is there a correlation between COVID-19 and endophthalmitis?
Ma'am, you are on mute.
She's mute.
Dr. Manpreet.
Yeah, can you hear me now?
Yes, ma'am.
Yeah, first of all, I would like to thank the organizers of All India Ophthalmic Society for giving me this opportunity. Now, coming to this question, there have been various studies published in various journals. In Indian Journal of Ophthalmology, there was a case series of presumed fungal endogenous ophthalmitis in post-COVID-19 patients due to Candida albicans. Another study in New York, there were the case series of 3 cases diagnosed with keratitis, progressing to endophthalmitis and vision loss. The organisms identified were Streptococcus pneumoniae, Serratia, and Candida. Various other organisms have been responsible for other things, other studies like Klebsiella, Stenotrophomonas. So in some of these, the organism was isolated from the vitreous fluid, but in some, the treatment was started due to the presumptively. Then there were the findings do not suggest that COVID causes endophthalmitis, but there is some relationship between the two. Maybe because of the poor immune response or nutritional deficiencies, or it may be also an incidental finding. So we need very many prospective, well-structured studies are required to address this, whether there is a definite correlation between COVID-19 and endophthalmitis.
Great. And this question, which I'm going to ask, is there in everybody's mind, not only in ophthalmologists, but even in ENT surgeons and clinicians. Why was there a disproportionately higher spurt of mucormycosis cases in India compared to other countries? Even countries surrounding India, Pakistan, Bangladesh, Sri Lanka, did not report such higher number of cases of mucormycosis. Why in India alone?
Yes, this is a very common question and important question. So the main cause what was attributed to this was the use and misuse of steroids and antibiotics. Since India has the second largest population of diabetic patients, and in the second wave, the more patients were admitted to the hospitals. And since there was shortage of oxygen and there was no glycemic control, so high doses of steroids were prescribed to these patients, which led to increased blood sugar levels, and they reached to approximately 600 to 800 also. Then another thing was the spore count outside and inside the ICUs also was found to be very high in some studies, like in PGI Chandigarh, a study was done, and they found very high levels of spore count. Then because of the tropical climate in India, the mycelial fungi, they thrive in this humid climate and can lead to invasive mold infections. There was an NIH study done by it was found that the COVID virus damages the pancreatic B cells, and the insulin level.
Yeah.
And the insulin levels were.
Can you summarize, Dr. Manpreet, please?
And there was iron metabolism also. So for a good source of nutrition for the fungus. So all these causes led to the increased incidence of COVID and mucormycosis during this period in India.
I think that's very well answered. Because of shortage of time, now I'll invite the next speaker, Dr. Anjani Khanna. Dr. Anjani Khanna is going to deliver her talk on ophthalmic practice slowdown due to COVID. Dr. Anjani, are you there?
Yes, sir.
Yeah. You can please start.
Screen visible?
Yeah, it is. Please. You can start the slide share.
Good afternoon, everyone. And at the outset, I would like to thank the organizers and Professor Bhalla for giving me this opportunity. So till now, we have seen the healthcare problems, the psychological problems, and even the microbiological aspects of COVID being covered so well. Now we'll see what is the economic impact of COVID on us as an ophthalmic community. So COVID wreaked in havoc. It caused widespread deaths, healthcare issues. We saw nationwide and statewide lockdowns, and Indian economy hit a low. We recorded the lowest GDP of 7.3% since independence, and definitely we as an ophthalmic community also suffered. There was a genuine fear in patients of stepping out of the house of the risk of contracting infection. There was genuine fear in ophthalmologists of the risk of contracting infection. In fact, there was a study in which 72.5% ophthalmologists didn't see patients during the first lockdown. Even if they wanted to, there was an inability of staff to travel and reach the clinics and hospitals. So a lot of us got infected, a lot of staff members got infected. So there was a lot of loss of working hours in ophthalmic practice. So all of this was going on. There was hardly any work coming in, but the fixed expenses as rentals and electricity had to go out. There was also added costs of the protective measures that we have to take now, PPEs and everything. So there was a lot of reduced paying capacity of hospitals and clinics. So this led to quite an imbalance of expenses and income. So so according to the study, there was 72.5% people who were not seeing any patients, and actually 1/3 of ophthalmologists were suffering from some kind of depression also during the lockdown. But every challenge and every adversity contains within it the seeds of opportunity and growth. So what we as a community and institution did was take a step back, take stock of things, and see where we could cut down the costs. So what we did and what can be done in future is to actually speak to the suppliers of consumables regarding better rates of things of pharmaceutical and other consumables, renegotiation of credit periods, asking for delayed payments or staggered payments. The calibration of salaries was done. So in our institution, none of the staff were laid off, but what was done that the people who had salaries of less than 50,000, their salaries were not cut, and that brunt was borne by the people who earn more. It was kind of divided and proportionally divided amongst the staff and the doctors. The fixed costs and maintenance, the renegotiation was done for the rent rates, and the discretionary spends like on marketing and all were absolutely cut down. So the focus was on daily, weekly, and monthly cash flow. So what happened was people were not purchasing equipment. So we got equipment at a reduced cost. The rentals were reduced. So we were actually able to open 3 branches and actually lead to expansion during this COVID pandemic. Teleconsultations were done by most of the ophthalmologists all over India, which helps us touch base with the patients to reassure them, and abiding by the regulations of telemedicine, we can at least help the patients as much as we can. Training of staff was done. So what was important that the staff were not laid off, but since they had less work, for example, elective surgeries were not happening. So the OT staff were idle. So instead of sitting idle, they were retrained for counseling or marketing, so that if any staff is down, the other staff can take their position. So staff should be made multifunctional. There were huddle meets with staff and doctors to keep each other's morals up, psychologically supporting each other. There's been a epidemic of webinars during this of doctors and also with patients to spread awareness, allay their fears, especially with the mucor epidemic rising up, and reassuring them. So what happened was the patients were not coming to clinics. They were actually sitting at home. They were actually not getting treated. So what most of the ophthalmologists saw was when the unlock happened, there was a patient surge. All of the pending cataract surgery cases turned into hypermature, most of them turned into hypermature cataracts, and they all came back, as with the other surgeries like intravitreal injections, etc. There was also a high rise of refractive errors due to screen use. Parents were very concerned about their kids using screens, and they came back for getting the refractive errors checked. COVID itself led to a lot of conjunctivitis and accommodation deficiency. There was also a mental makeup that, we don't know when the third wave is going to hit. So during this unlock, a lot of patients came to get their glasses checked because they don't know when another lockdown is going to happen. Mucormycosis came as a very unfortunate epidemic. A lot of cases were seen, but many more were just scared. Even the patients who did not have COVID came rushing to the OPDs to ask if they were infected with black fungus. So we as an institution, we lost work about 60 to 80% during the lockdown, the first and the second. But when it opened, we gained work and it was 140% back. So the net was a loss of 20 to 30% of work, which is under the range of predictability. So what I want to say is that though there was a loss of work, strained finances, risk of contraction of infection, emotional losses, but we are a resilient race. So the lesson learned and how to prepare for the third wave is not to take things for granted, do cost cutting wherever possible, make the staff agile and multifunctional so that when one staff is down, the others can take their place and we can keep the show running. This is the time to psychologically, technically, and operationally update ourselves. So this is the time to for training and regrouping.
Yeah.
And tough times don't last, but tough people do. So when troughs like this come, what we can do is take a seat back, adjust gears, and prepare and sow seeds so that when things come back to normalcy, we can bounce right back up. Thank you.
Right. Thank you, Anjani. I would invite discussant for this talk, Dr. Amit Shah, sir. Are you there?
Yes, I am right there.
Yeah. Dr. Amit Shah, yes, we all know that ophthalmic practice has been adversely affected like all other medical practices in COVID-19 and lockdown. So how do you think, how difficult it is to maintain the setup and pay salaries to all the employees with lesser income, sir?
It is going to be very difficult. It was very difficult since last 1.5 years, to pay the salary, etc. And, we have to include the cost of masks and sanitizers and the PPE kit, etc. But we have to continue with the same just because, patients are also suffering by the same COVID thing. And they cannot also give the proper payment also. So we have to accommodate in any way. Usually, we have a high volume center in Ahmedabad. We are operating nearly 450 to 500 patients in a month. It has been reduced to now 200 to 250 patients only. But we have to wait and watch. We can't do everything. I had my 9 centers all over the India. I had to close my 2 centers. I can't help it just because of salary and all kind of those things.
And what do you think is a better strategy, sir? Is better to lay off the employees or retain the employees with reduced salary? I know it's a difficult question, but what is a better strategy?
With the reduced salary, we have to continue the whole thing. We have to run the show.
I think very, very well said, sir. Very well. Thank you, sir. Now we invite the next speaker, Dr. Saurabh Deshmukh. Dr. Saurabh Deshmukh is going to enlighten us about impact of COVID on ophthalmic training during residency and fellowship. Dr. Saurabh was finished his fellowship in Viteo Retina, and I think he'll be the best person to tell us how the fellows' perspective is on this issue. Saurabh, or yours. Saurabh, I'll request you to just try to finish in 3 minutes.
Is the screen visible, sir?
Yeah, it is visible. Please start.
Good afternoon, everyone. At the very outset, I would like to thank AIOC and Dr. Bhalla, sir, for giving me this opportunity. I'll be talking on impact of COVID on ophthalmic training, a fellow's perspective. I was a Vitreoretinal fellow at Sri Shankardev Netralaya, which is a tertiary eye care center and a center of excellence in Northeast India, which caters to the 8 northeastern states, along with countries like Bhutan, Nepal, and Bangladesh. So while I was just starting my journey as a VR fellow, COVID-19 struck, and there was a national-wide lockdown, which was initiated in March 2020. So resulting in travel ban and a once hustling retina department came to a standstill. So as a fellow, I expected my training to provide me with diagnostics and management of vitreoretinal diseases. And I wanted to be also a part of academic discussions, webinars, national and international conferences as well. Also, a few publications would have been a cherry on top. But COVID seemed to turn all the aspirations into a distant reality. Just while I was learning to master retina, my institute was converted into a referral center because most of the medical colleges were actually converted into the COVID referral centers. So I realized that this was my chance to brush up on my comprehensive ophthalmology skills, a rather missed opportunity in the subspecialty fellowships. Also, the operation room or the OR, every fellow's favorite place, also closed doors. At this junction, my mentor came to my rescue and provided me with his video library. So hours of watching these videos and editing them also helped me and enlightened me with the practical surgical tips. Also, one-on-one discussion became a daily routine. Wet lab training also became important and life gave me lemons to buckle up. Also, slowly I shifted to goat eyes and cadaveric eyes, which helped me to shorten my learning curve as well as surgical time. Ultimately, the eyes see and the hands perform what the mind knows. Also, while the borders were closed and cancelled conferences, meeting the stalwarts in the VR surgery field was almost impossible. But virtual platforms came to the rescue. And not only did I get a chance to present on multiple platforms, I also got to meet the stalwarts through the virtual webinars. Also, less workload helped me concentrate better on my publications. And during this COVID pandemic, I was able to publish more than 15 articles during this period. With ample time to spare, I started my own website called as ilearn.in in April 2020, which was a venture very close to my heart. So today, iLearn has more than 500 visitors every day and has 3,000 subscribers. And it helps the PGs in scoring well in their exams by providing notes as well as question banks. And I don't think iLearn would have been possible without the COVID pandemic. Also, finally, all that ends well. I completed my fellowship in May 2021 with 2 months of voluntary extension to cover up for the surgical loss which I incurred during the COVID pandemic. And my institute was kind enough to allow that. So what we learned during COVID pandemic is that we need to be jack of all trades and master of all when it comes to the eye. Also, learn from your mentor's mistakes. Video assisted skill transfer is an inexpensive boon if well utilized. Also, we need to remember that publish and flourish because today academician is the new clinician. Also, be others and give back. I would like to end by saying, be strong now because things will get better. It might be stormy now, but can't rain forever. Thank you so much.
Thank you, Saurabh. I would invite Dr. Abjeet Kaur to discuss this topic of Dr. Saurabh. We all know Dr. Abjeet Kaur is a renowned oculoplastic surgeon and she is a brilliant academician, professor and head at KGMC. Ma'am, how do you think has this pandemic really affected the training of DNB fellows, not only skill-wise academically, but also psychologically? Are you there, Dr. Abjeet, ma'am?
Yes, I'm there. I'm there.
Yeah.
At the outset, I would thank the AIOC and also congratulate Dr. Saurabh for his very beautiful presentation. Actually, a lot of what Saurabh has said is what happened. See, nothing actually stopped other than the physical surgical part. That is the only thing which stopped. Otherwise, academics continued in several forms in major institutions. I think large number of us actually did more teaching than we would have done with a running OPD and a regular surgical theater on. The tools have been more than many. We have had in-house discussions. We have had virtual case scenarios. We have had OSCE to help the children in their tests, and also have made a system in my institution. I have the system of regular monthly evaluations. So there is no slackening as far as the learning is concerned. The only two issues that I feel, although you do things on both eyes, you do cadaveric dissection, but still that human touch of bleed and the real tissue, that is something which definitely has taken a beating. The second thing which I feel is that the human aspect, the touch of a patient, the counseling, the ATCOM, which is such an important part of our learning of any subject, that has taken a little beating. Otherwise, the academic content is available on the net. And that also goes to say that you can train engineers through books, but you can't make doctors through books. So that is one issue that I would like to highlight, that no matter how much a degree you may get, how much your fellowships you may do, but the real learning will happen when you have the real patient, because the real mistake or the real success will happen only then. You get well equipped, there is no doubt. All the pitfalls are filled, no doubt. But still, I would still say I would wish that the pandemic finishes and we are back to our normal patient-human relationship and actually working on the success of a patient.
Those are pearls of wisdom from Dr. Abhijit ma'am. Much as I would like to have more discussion from you, the paucity of time does not permit me because we still have one more talk to go. Thank you so much, ma'am. Now I would...
Yeah, I understand that. I understand. Thank you.
Thank you so much, ma'am. Thank you so much for understanding and being there with us. Now the last talk is Digital Eyestrain, Epidemic in COVID Pandemic. I'm going to... Yeah. Yeah. Is my screen visible?
Yes,
Right,
sir.
yeah. So I'm going to talk on the digital Eyestrain epidemic that has occurred in the era of COVID pandemic. Lockdown and isolation measures have rapidly increased the screen time, and digital exposure, device exposure has really resulted online education, online classes, online work from home and entertainment pastimes on Netflix, etc. And so much so that 50 to 90% of individuals have some of the manifestations related with computer vision syndrome. And Indians suffered the maximum. And it was found that 23% of the population was devoting more than 6 hours average screen time per day. And the symptom that resulted was asthenopia, ocular surface related, visual and extraocular. There was redness or irritation of eyes because of straining at the bright glaring screen. There was blurred vision due to screen glare, general fatigue from really concentrating and converging on small fonts. And there was other systemic symptoms like headache and body aches and backaches. And digital eye strain results in evaporative dry eye. Why? Because there is incomplete blinking. Blink rate decreases from 18 to 3 per minute. And what happens is, if there are additional factors like decreased humidity in AC rooms and uncorrected refractory error, your problem is compounded. And decrease of blink rate, what it does is that decreased blink causes the gaze angles to be higher because you are looking at a screen which is slightly higher. Palpebral aperture becomes larger, leading to faster evaporation. And also the tear film is not properly spread. So there is strain on the ocular muscles because the eyes in a constant state of accommodation and convergence. This taxes the extraocular muscles, and blurring occurs because there is inability of the accommodation to relax. And the continuous shifting of gaze from the desk, from the screen to the keyboard to the documents really result in a lot of eye strain. And continuous exposure to blue light is another bugbear because this wavelength of 482 nanometers is not very healthy for our eyes. And it was found that children aged 6 to 12 were spending 3 times the amount of time in front of screens than in pre-pandemic areas. This was publication in IGO November 20, where they found 60% was spending 6 to 11 hours and 48%, another 48% was spreading more times. This was another publication in European Journal where they found that 79% were using smartphone as the digital device. And the symptoms were, as I enumerated earlier, besides headache and eye pain, there were also watering, burning of eyes and itching, etc. And the commonest device was smartphone for online classes and also for younger adults, and for older adults, it was laptop and desktop and they were attending classes for more than 8 to 12 hours per day. And this was, if we compare the pre-COVID with the post-COVID area, where the prevalence of dry eye was 18%, it increased to 50%, and 40% of children were using the smartphone for school projects only, whereas now 96% are using for online classes. When there were 3% spending more than 5 hours, now we have 50%. So the incidence really increased, and the risk factor was age more than 14 years, smartphone duration more than 5 years, and also mobile games for more than 1 hour per day. And if the screen distance is less than 50 centimeters, there is another entity called video game visual syndrome, which is different from computer vision syndrome in these following features. And there is also increase in childhood myopia because of increased time on the screen. I'll just summarize. And there is increased incidence of esotropia, blue light effect, as I enumerated earlier, of 415 to 455 nanometer has been harmful. And these are the various sources of blue light, which causes not only ARMD, but also cataract. So what are the measures we should undertake? Comprehensive eye examination, proper lighting, so that the background light is not too glaring, and the computer should not be in front or on the opposite side of windows, but on the side of windows. We can use anti-glare screen, we can use blue light blocking glasses, we can upgrade our display like LCD screens, we can adjust our display settings, we can increase the font size, and the contrast should be like this. The upper one, which is effective, and not the lower one. Color temperature, blue light should be decreased because the temperature of blue light is much higher because of shorter wavelength and higher energy. Wear the right glasses, and also be alert to the type of your posture. Blink more often. Exercise your eyes. After every 20-second, look at distance of 20 feet for 20 seconds after every 20 minutes. And then you can have this posture where the top of your screen should be in alignment with your eyes, and the angle made should be about 35 degrees. Don't overuse your digital devices, particularly 1 hour before sleeping. And this is the ideal distance. It is called Bilton's 1 to 10 rule, according to which mobile phone at 1 foot and TV at 10 foot should be kept. Font size, and we should encourage children more of outdoor activities. This is the American Academy of Pediatrics, which have given that children less than 18 months, there should be no screen exposure, and 18 months to 5 years should have just 1 hour per day. We can use ideal tear substitute for the dry eye, which results. So I'll just summarize and say that policymakers have to come up with a stringent guideline to deal with this emerging threat, because digital eye strain and myopia progression may become significant public health issues during COVID-19 pandemic. Thank you everyone for your kind and patient hearing. And I would now once again thank all my speakers, chairpersons, Dr. Nichlani, Dr. Abjeet, Dr. Jagdish Rana, Dr. Chadda, Dr. Vinita Ramnani. Dr. Vinita, just brief comments from you before we conclude the session.
Sir, we are in a digital era, and in COVID time, it has increased a lot. So we should be giving digital detox. And what you said is really good, but then we should prevent myopia in children, because that is a pandemic, and it has been found that there is a progressive increase in the numbers of myopia. It has seen in the study from China that it has gone to the percentage of 400 time rise in the prevalence of myopia in a 6 years children, and to the extent of 200% rise in 7-year children, and to the extent of 40% in 8-year children. So we should be very careful about our younger children. One thing I want to comment, that blue light is not only harmful, but sometimes it is good for our mood elevation and for cognitive functions. But then we should stop our digital gadgets 2 hours before sleep to have a proper circadian rhythm. Thank you so much, sir, for inviting such a nice discussion. Thank you so much.
Thank you, everyone. Thank you.
Thank you so much, Dr. Vinita. Thank you, Dr. Jatinder. Also, thank you to all the analysts and experts, and also all the participants.